So welcome to the day 6 of the topic. So today we are going to discuss about Merkel's diverticulum, then superior mesenteric artery syndrome, Hirschsprung disease, mesenteric ischemia. So mesenteric ischemia, then we will be discussing about the ileostomy or colostomy. Then we will go for the appendix chapter. Okay, so without wasting much time, let us start with the discussion. And I think you're all in the mid of preparation. So preparation is going to be very difficult for you all. Finally, you're going to have a 4 core subjects. Try to split up and try to read daily basis. After seeing the video, just go through the notes whichever we are taking through this session. Okay, copy down all the notes, pause in the middle and just copy down, because these notes are going to be helping you tremendously before your exam. Okay, these are the key points which you will be expected. So vandiya padikkiradhoda keywords mattum padichittu pona kuda exam you can easily pass. That is my principle, and that is how I actually cracked the exams. So I request you all to do the same, and let's start with the today's discussion. That is going to be on Merkel's diverticulum. Merkel's diverticulum, it's nothing but it's a remnant of the vitello-intestinal duct. Okay, so this is going to be along the anti-mesenteric border. It's going to be due to the outpouching of all the layers. That's why we call it as a true diverticulum. And this is going to be independent, having an independent blood supply, and you are going to follow a rule of 2. What is this rule of 2? So you're going to have 3 important points. What are those 3 important points? Number 1, 2% population that is going to be present 2 inches long, and it is going to be 2 feet proximal to the ileocolic junction. Now coming towards presentation, how your thing is going to be presented in your exam. Okay, how you are going to be presented, the case presentation is going to be. Number 1, asymptomatic. So if it is going to be asymptomatic, treatment is going to be nil. You don't want to do anything. You're going to just observe. If there is going to be a diverticulitis, if it is presenting as diverticulitis, you're going to cut and you're going to do a diverticulectomy. And if it is going to be hernial sac, what you're going to do, this is hernial sac. Now this is called as Litter's hernia. This we will be discussing when we are discussing about the hernia. And next is going to be perforation. What is perforation? So when there is going to be a perforation, what happens? There is going to be peritonitis. There is going to be a peritonitis. What are the 3 cardinal symptoms of peritonitis? Rebound tenderness is going to be there. And number 2, there is going to be guarding and rigidity. Okay, so the treatment is going to be resection followed by anastomosis. Bleeding, most common, this is going to be present in the children. You're going to have ectopic mucosa, either ectopic mucosa from your stomach or ectopic mucosa that is going to be coming from your pancreas. So most common gastric mucosa, second most common pancreatic mucosa. Now, what is going to be the investigation of choice? Technetium 99 percutaneous the can or pentagastrin. This is going to be helpful in detecting the bleeding of 0.1 ml per second bleeding and detect pannu. And what is going to be a management? You're going to do angioembolization followed by diverticulectomy. And obstruction. If there is an obstruction, guys, listen to me. Most common, this is going to be present in the adults. And most common cause in the adults, if you're going to ask me, that is going to be obstruction of your Merkel diverticulum. How? By intersusception. Remember, most common cause of obstruction in Merkel's diverticulum is intersusception. But intersusception is most commonly seen. That is not your Merkel's diverticulum. That I want you all to remember. And twisting of bowel around your Merkel is going to occur. That is also going to be a cause of obstruction. And then cancer, very, very rare. Okay, most commonly neuroendocrine tumors can be presented. Next, we are going to have this so-called mesenteric cyst. What is mesenteric cyst, guys? It's a Tilloch's triad. You have to remember Tilloch's triad. 3 important features are going to be there in Tilloch's triad. Number 1, periumbilical swelling will be there. Number 2, there is going to be a transverse lower band of response. Okay, there's going to be a transverse band of resonance. And number 3, moving at right angle to the attachment of mesentery. So Tilloch's triad in keta idu moonu eludano, but Tilloch's sign abdin exam la ketanga, that is just moving at a right angle to the attachment of mesentery. That is called as your Tilloch's sign. Now this is going to be divided into 2 important things. One is your chylolymphatic, other is a enterogenous. What is chylolymphatic? It is going to be the most commonly sequestered, the most common type of your mesenteric cyst. So this is going to be sequestered lymphatic tissue. It's going to be a thin wall, clear fluid, and it is going to be having an independent blood supply. Whereas your enterogenous, it is not going to be independent blood supply. There is going to be a deep bowel tissue thickening. So you're going to have thick walls and turbid fluid. When you're going to have thick walls, what is going to be a management? You want to resect them. So you're going to resect an anastomose. Whereas in your chylolymphatic, it's going to be lymphatic. So it's going to be a lymphatic tissue. What you have to do? Enucleate those lymphatic tissues. Now, meconium ileus. What is meconium ileus? Delayed passage of meconium is called as meconium ileus. So most common feature which is going to be a clinical feature is going to be thickened meconium. So on X-ray, you're going to see a soap bubble appearance, that is otherwise called as no-osser appearance or no-osser sign. Okay, new osser sign. And what is going to be the differential diagnosis? Close differential diagnosis is Hirschsprung disease. Okay, so what is going to be a management? Gastrographin enema. You have to give gastrographin edema. Okay, so this is very important. I'll show you certain images, guys. This is going to be your meconium ileus. Can you see? This is going to be a meconium ileus. Okay, what is this Bishop-Koop operation? Bishop-Koop operation, this is going to show a completed procedure after a grossly distended ileum has been resected. Okay, because intestinal continuity is going to be preserved, early closure of ileostomy is not essential in these conditions. Next, you are going to go for the SMA. A very, very important topic is going to be your SMA, that is your superior mesenteric artery syndrome. What is superior mesenteric artery syndrome, guys? There are otherwise called as Wheeler's syndrome. This is a very important question that can be asked in your exam. It is a Wilkes syndrome, otherwise called as superior mesenteric artery syndrome. Rumba easy. So you're going to have aorta, you're going to have superior mesenteric artery. Between your aorta and the joining of your superior mesenteric artery, you are going to have a fat. You're going to have a perinephric pad of fat. So in the pad of fat, like your perinephric pad of fat, so kidney la eppadi ungalku support kudukudo அந்த மாதிரி ஒரு perinephric pad of form ஆகி இங்கேயும் ஒரு pad of fat இருக்கு. அது டியோடினமா சப்போர்ட் பண்ணுது. டியோடினம் தேர்ட் D3 இருக்குல்ல, தேர்ட் பார்ட் ஆஃப் டியோடினம் அதை சப்போர்ட் பண்ணி இருக்கு. ஸோ இப்போ இந்த D3 சப்போர்ட் பண்ணி இருக்கிற pad of fat decreased இருக்கு because of some anorexia, rapid loss of weight. What happens is the angle has been reduced. When the angle between your superior mesenteric artery and your aorta is going to be reduced less than 20 degrees, normal angle is 25 to 45 degrees. If it is going to be less than 20 to 22 degrees, then it is going to be causing a compression of D3. So when there is going to be compression of D3, what happens? There is going to be a bilious vomiting. So how do you diagnose this? By using CT angiogram. You're going to diagnose this by using CT angiogram. And what is going to be a management? You're going to manage it by weight gain. So weight gain or duodenojejunal anastomosis. Okay, that is duodenojejunectomy. Or you can go for strong procedure. What is strong procedure? Either duodenal derotation or cut ligament of triads. So you're going to cut the ligament of treats. Okay, so then comes your paralytic ileus. So paralytic ileus, bowel is going to be stunted. So it doesn't contract. Clinical features are hypokalemia, hypothermia, uremia, and hypothyroidism. These are the four important features of the paralytic ileus. Now I will show you certain images. Okay, so of your paralytic ileus, which is very important. So this is going to be a thumb printing sign. I will be discussing about thumb printing sign in a very short while. Okay, so before going to there, I wanted to discuss about this very important concept that is going to be your acute adynamic neuromuscular states of small intestine with dilatation. That is going to be your ileus, paralytic ileus. So that is going to be a ileus. What is ileus basically? Paralytic ileus na disruption of normal propulsive ability of the intestine due to malfunctioning of contractile activity in the absence of mechanical obstruction. So that is called as your adynamic okay, that is going to be called as your adynamic intestine. Okay, so before moving into there, I just wanted to discuss few things about this adynamic. Okay, guys, listen to me. Adynamic அப்படின்னு நம்ம சொல்றோம் பாத்தீங்களா? So அப்ப எதனால நம்ம அதை adynamic னு சொல்றோம்னா, okay, what basically happens here is there is going to be a congenital megacolon or Hirschsprung disease. So basically what happens, your muscles are not going to function. Basically what happens, your muscles are not going to function. Since your muscles are not going to function, why muscles are not contracting? Because of the loss of nerve supply. Who is going to supply the nerve? Ganglionic cells from your Moyer-Bach and myenteric plexus. So when the absence of ganglion cells in the Moyer-Bach or myenteric plexus, that is going to cause a functional obstruction. That is going to be a Hirschsprung disease. But there are various causes, okay, various causes, not just Hirschsprung disease. There are various causes. That is what we will be discussing in detail. Okay, so you have to understand that the contraction of your intestine is going to be controlled by intestinal cells of Kajal. Then you're going to have your neurogenic control by your ANS, CNS. Then you're going to have chemical control mechanism by the local paracrine action. So the risk factors of ileus is going to include your recent surgery, any recent surgery, okay, any local inflammation like peritonitis, severe acute pancreatitis, or electrolyte disturbances, hypokalemia or hypercalcemia, acute endocrine disturbances like your hypothyroidism, diabetic ketoacidosis, and if you're going to take opioids, medications. Okay, so you're going to have a bowel handling that is going to handle two types. Either there is going to be acute stress response or chronic prolonged inflammatory response. Acute stress response inhibitory signals release pannu, that is going to be adrenergic reflex. So and you're going to have your HPA axis activating the catecholamines. All these are going to cause immediately decrease in the motility of your decrease or motility, absence of motility. Okay, so that is one pathway. Second pathway is chronica. What happens? Inflammatory cells are going to come and act, mast cell activation, macrophage, neutrophil migration. All these things are going to cause afferent sensitization and inhibit your spinal reflexes, especially your adrenergic reflexes, and prolonged local and distant decrease of abolition of motility will be leading to this motility disorder, or that is what we call it as adynamic bowel obstruction. Can you see here? This is a 22-year-old woman who had a widespread dilatation of the small intestine, that is ileus, secondary to having a driving inflammatory response. I told you, right, prolonged response. So and the cause varum. After the management, how do you manage this ileus? So ileus is managed by nasogastric drainage and restriction of oral intake, and there is evidence of improvement. So prolonged, now what is going to be the investigation of choice you're going to do? Investigation of choice is going to be your CECT. After doing a CECT, okay, particularly this is going to be lasting for more than 7 days, open laparotomy is needed. Okay, so can you see here? This all we already saw. These are the obstructions that are going to be present. Interception idellame nama paathutom. Next ipo nama paaka poradhu enna, we are going to see a term called as pseudo obstruction. So before I move towards pseudo obstruction, we will talk about this congenital megacolon or Hirschsprung disease. So Hirschsprung disease, I told you already, it is the absence of ganglion cells in the Auerbach and mesenteric plexus. There is a functional obstruction. This is common in the Down syndrome and your Men's syndromes. Okay, so what are the features? Non-passage of meconium, number 1. Distension or constipation, number 2. And due to the mutation in the gene coding, of glial-derived neurotrophic factor. Okay, glial-derived neurotrophic factor. What is going to be the investigation? Investigation is going to include full thickness rectal biopsy. What is going to be your full thickness rectal biopsy? So before moving to that, remember, so it's the most common cause of non-passage of meconium sonella. So most commonly it is seen in the Down syndrome and Men's syndrome. Men's syndrome particular in the type, not type 2A and 2B. Okay, most common cause of non-passage of meconium, distension and constipation. Okay, cause mutation in the glial-derived growth factor, glial-derived neurotropic factor, and you're also going to have a mutation in the RET gene. Okay, investigation of choice, you're going to go for full thickness rectal biopsy. There is going to be loss of ganglion cells. What are you going to see? Loss of ganglion cells. There is going to be hypertrophied trunk is going to be there, and on immunohistochemistry, you're going to have the presence of acetylcholine esterase. So there is a dilatation of normal bowel proximally, and constricted bowel you're going to see lacking the ganglion cell when you're going to see that in the barium enema. What is the best method to diagnose? It is not barium enema, it's an intraoperative frozen section biopsy. So this is called as Donhal-Swanson wave. Okay, SWAVE. So that is called as Donhal-Swanson wave. Swanson's wave. It's not wave, it's Swanson's wave. Okay, so not is going to be the management, bypass or resection of abnormal portion. Then you are going to have a very important thing, mesenteric ischemia. What is mesenteric ischemia? Mesenteric ischemia, they are going to divide into two. So there is going to be ischemia and a loss of blood supply. So mesenteric loss of blood supply agade. Two common cause, acute mesenteric artery embolism, acute mesenteric artery thrombosis. Acute mesenteric artery embolism is the most common cause, and source of embolism is going to be heart. So what is going to be the risk factor, guys? IHD and atrial fibrillation are risk factor. So bowel attack, sudden abdominal pain, which is going to be ending with the peritonitis. That is going to be the clinical feature. Investigation of choice is going to be a CT angiogram, and management is going to be early presentation, that is within 6 to 8 hours embolectomy, and later gangrene vandrum. Gangrene vanda you have to do resection. So it can lead to short bowel obstruction, short bowel syndrome. Then you are going to have your acute mesenteric artery thrombosis. This is due to the secondary thrombus atherosclerosis. So bowel angina is most common. Postprandial abdominal pain can occur, and food avoidance Okay, and weight loss are the cause. So investigation of choice is going to be CT angio, and your management is going to be bypass grafting. Okay, so can you understand? Now let me show you certain images that will make you clear. And before ending, okay, see here, mesenteric ischemia. This is the mesenteric ischemia or image, and this is going to be Hirschsprung disease. This is Hirschsprung disease. Can you see here? Proximal area, distal area, you cannot see. This is going to be your proximal area, and this is going to be your distal area. This is going to be your distal area. Okay, can you see here? And what does your thumbprint sign? This is called as your thumbprint sign. Can you see here? So this is going to be a thumbprint sign. This is not just present in your mesenteric ischemia, but it is also present in the inflammatory bowel disease. It is present in the pseudomembranous colitis. It is present in diverticulitis, amyloid, typhitis, or it is present in the hemorrhage. Okay, and next is going to be your colonic pseudo-obstruction. This is mainly seen in the patient with Parkinsonism, Alzheimer, and retroperitoneal hematoma. So what is a pseudo-obstruction? It is an acute massive dilation of your colon with obstructive symptom, but in the absence of any mechanical obstruction. So the symptoms are going to include bowel obstruction. There is going to be abdominal distension, absolute constipation is going to be there, and later they can cause vomiting, skin to mechanical, large bowel obstructions, etc. On abdominal examination, what you're going to find is a grossly distended. So there is going to be a gross distension. So there is a risk factor for acute colonic pseudo-obstruction. What are those risk factors? So you have abdominal distension, you're going to have a tympanic, and in uncomplicated cases, they are not supposed to be tender. And if there is tenderness, then that means that there is some complications. So there are some serious risk factors of acute colonic pseudo-obstructions, including your neurological symptom. Another Parkinsonism, Alzheimer, post-retroperitoneal hematoma, all these conditions will be moving forward for the acute colonic pseudo-obstruction. These are the tables from your Bailey and Love. So the diagnosis is going to be relying upon the clinical observation. CECT is going to be the definitive choice. CECT is going to be a definitive choice because you wanted to rule out the dynamic causes. So then you go for the, what is going to be your management plan? Number one, correct the fluid and electrolyte. Stop or reduce offering offending drugs like your anticholinergic, opioids, calcium channel blockers, etc. Then empty the rectum by using enemas. And then colonoscopy is going to be done, flatus tube. So you're going to do endoscopic decompression is done. Then pharmacological decompression you're going to do by intravenous neostigmine. Neostigmine you're going to give unless there's a risk of any arrhythmias or any bronchospasm. This is called as catch-pole regimen. I want you to take a note of it. So this is called as catch-pole regimen. So what is catch-pole regimen? Abdin exam la ketangana, catch-pole regimen is nothing but giving intravenous neostigmine for the patient of pseudocolitis. Okay, wow. So then what is going to be the cause of intestinal pseudo-obstruction? There are several causes as we discussed. And how do you manage it? By nutrition, analgesia, prokinetic, antibiotic, etc. So this is going to be a rough tableau column given in your Bailey regarding your megacolon and megarectum. So congenital, it is going to be classically, it's going to be due to Hirschsprung disease. And secondary, you want to remember the CNS disease like Parkinson, dementia, amyloid, and spinal cord injury, acquired cause. Primary, megarectum primary, it's going to be congenital, ultra short segment Hirschsprung disease. And inadequately resected Hirschsprung disease is also a cause. And then anorectal malformation is also one of the cause of megarectum, which we will be discussing it later. Now, starting with your appendix, remember there are certain important points you need to understand in the appendix. Are you clear till now? Okay, so this appendix is very important. So what we will do is from this only today's topic. So the SMA, yesterday we have to complete, but unfortunately we couldn't complete. So I have rushed through those topics. And importance, it's going to be little less. That's why we have taken less time. So now we will be starting with the very important chapter that is going to be appendix. So appendix, when you're going to consider, that is going to be having a very important role in your exam as well as in your practical skills. Okay, so appendix, it is a vestigial organ. Okay, it's a vestigial organ or a cow or requirement, namak requirement illa, but still it is going to be playing a major role because it is going to house bacteria and cause infections. Okay, so you have to understand the various positions of appendix. So appendix, it is going to be either most commonly it is going to be a retrocecal behind your cecum. Okay, it's going to be invisible. Okay, it's the most common. Then you have subcecal at 6 o'clock position, pelvic at 5 o'clock position. in front of your ileum, you're going to have pre-ileum. Behind your ileum, you're going to have post-ileum. So post-ileum is the least common and retrocecal is going to be the most common. Okay, 2023 la NEET PG la they have asked just this image they have put, and in the image they have given or either label பண்ணிட்டு இது எந்த பொசிஷன்ல இருக்கு, retrocecal, subcecal, pelvic, pre-ileal, post, அவ்வளவுதான். Very simple question they asked you. Okay, that's going to be a very easy cakewalk for you all if you get such exam in your exam. Okay, such question in your exam. Now moving on towards this appendix. Appendix, as I already told you, it's a most common cause of retrocecal. Most common is going to be your retrocecal and least common is post-ileal. Appendicular base, it's going to be the junction of 3 tinea coli. Appendicular artery, it is a branch of ileocolic artery. It's a end artery. Basically, it is a end artery that you need to understand. And accessory appendicular artery, it's an artery of Seshachalam. So it's a branch of post-cecal artery. Now surgical anatomy, you need to understand what is McBurney point. Okay, sixth point add panikonga. What is McBurney point? McBurney's point. So McBurney's point is nothing but it is a constant site for the base of appendix where tenderness is elicited. So from your umbilicus to your anterior superior iliac spine, you're going to draw a line at the medial, lateral 1/3, medial 2/3, you're going to put a point that is going to be called as your McBurney point. That is going to be called as your McBurney point. This is going to be the constant site of appendix where tenderness is elicited. Okay, so appendicitis, it is going to be an inflammation of your appendix. It is going to be of two types. Either it is going to be due to some obstruction, secondary to some obstruction of lumen, or it is going to be categorical non-obstructive. So most common cause of your secondary obstruction of your lumen is going to be your fecolith. So fecolith, what is going to be the other causes? Other causes include roundworm, carcinoid. So other causes is going to include roundworm, carcinoid disease, and your foreign body. Okay, any foreign body obstruction at that particular area will also cause infection. Okay, now coming towards your appendicitis. So what is going to be the symptoms you are going to experience? What are the symptoms, signs and symptoms you are going to experience? Okay, that is what we are going to discuss now. What are the signs and symptoms of your appendicitis? Just write it down. Symptoms, number 1, you are going to have a pain. Okay, you're going to have pain at abdomen. Okay, then you're going to have your nausea and vomiting. Nausea and vomiting is going to be there. Number 3, the patient will be experiencing anorexia. And number 4, you're going to have fever. Number 4, there is going to be fever. This is going to be your symptoms. Now coming towards your sign. Now discussing about the signs. Remember, you're going to have number 1, tenderness at the McBurney point. Tenderness at McBurney point. Tenderness at McBurney point, McBurney's point. Okay, this is very important. Tenderness at McBurney's point. And number 2, you're going to have a Rav-Singh sign. What is this Rav-Singh sign? Okay, Rav-Singh sign abdina pain at the right iliac fossa on pressing left iliac fossa. So when you're going to press left iliac fossa, there is going to be a pain at right iliac fossa. So that is called as Rav-Singh sign. That is called as your Rav-Singh sign. Very, very important. And tenderness at the McBurney point is going to be the first point. Second point, Rav-Singh sign. Third one is going to be a Soya sign. What is Soya sign? It is the flexion against resistance causes pain in the right iliac fossa. So when there is going to be flexion, so flexion against resistance is going to cause pain in the right iliac fossa, pain in right iliac fossa. That is going to be your Soya sign. And number 4, you have to remember obturator sign. What is obturator sign? When you're going to have a flexion and internal rotation, it gives rise to pain. So when you're going to do a flexion and internal rotation of your leg, that is going to give rise to pain. Okay, flexion and internal rotation is going to give rise to pain. And number 5 is going to be your Aaron sign. What is Aaron sign? Aaron sign is nothing but when you're going to press your right iliac fossa, that is going to lead to pain in the epigastrium, When there is going to be a pressing in your right iliac fossa, that is going to cause pain in the epigastrium. That is going to cause pain in the epigastrium. And number 6 is going to be your Dunphy sign. What is Dunphy sign? Pain on coughing. Okay, that is called as your Dunphy sign. Pain on coughing. Okay, so again I repeat, what are going to be the pelvic signs? Soya sign and obturator sign. These two are going to be a pelvic sign. These two are going to be pelvic sign. And what is Aron sign and what is going to be your Dunphy's sign? These two are going to be non-specific sign. These two are going to be non-specific signs. Okay, you're going to have your tenderness and Rovsing sign. So motto R, again repeat along with me. Number 1, tenderness at the McBurney point. Number 2, Rovsing sign. That is going to be when you're going to press your left iliac fossa, pain is going to be in the right iliac fossa. Number 3, Soya sign. Soya sign of flexion against resistance is going to cause pain in the right iliac fossa. And what is going to be the number 4? Number 4 is going to be an obturator sign. What is obturator sign? Flexion, internal rotation is going to cause pain. So flexion, internal rotation is going to cause pain. Flexion, internal rotation is going to cause pain. And what is going to be the number 5? Aron sign. What is Aron sign? Pressing your right iliac fossa is going to cause pain in the epigastrium. And what is Dunphy's sign? Pain on coughing. Okay, not specific. It is not specific. Pain on coughing is going to be there. What is going to be your lab finding? Lab finding, there's an increase in the TLC. What is TLC? Total leukocyte count. And there is going to be a neutrophil rise. There is going to be a neutrophil rise. Now you have to talk about very important one, that is going to be your Mantel's criteria. Okay, so Mantel's criteria, okay, we will see the differential diagnosis of acute appendicitis in children. Gastroenteritis must be ruled out. Merkel's diverticulum must be ruled out. Intersusception should be ruled out, because I already told you in intersusception also there is going to have a pain in the right iliac fossa. Therefore, it is very important. Lobar pneumonia must be ruled out. In adult, regional arteritis, ureteric colic, then you're going to rule out the torsion of testis, pancreatitis. In adult female, again pelvic inflammatory disease, ectopic pregnancy has to be ruled out. Endometriosis has to be ruled out. Now coming towards your Mantel's criteria. So this we call it as Avogadro score. Avogadro score or Mantel scoring system. What is this Avogadro score or Mantel scoring system? You're going to have certain points for each and everything that is going to help you in calculating whether this patient is going to have appendicitis or not. I'll share you an interesting story that happened in my UG days. So what happened is there was a patient who was admitted in one unit. They came with a complaints of abdominal pain, same typical pain and all those symptoms, whichever we saw, like your pain abdomen, anorexia, vomiting, fever avlo illa, but vomiting irundhathu, pain abdomen irundhathu. So when we examined the patient, there was not actually very much feature. I'll tell you what are the feature I saw and what are the features are not there. What happened is our unit chief, he told that the patient cannot be done a surgery. Okay, surgery panna mudiyadunte unit chief told. Then what happened is the patient was like, he was like, no, the patient is having appendicitis. So their attendant told that, no, we wanted to have him surgery here. So, but our chief told strictly that there is no need of surgery for this patient. So I am not going to do surgery for this patient. Then it escalated to the higher level, MS and everyone. So everyone were like, since our unit chief told you they cannot do, but they didn't touch the patient. But unfortunately, what happened? They went outside, they went to some hospital, the surgery was done, but unfortunately, the patient succumbed in the bed. So why? Because unnecessarily, we should never take surgery. That is why you have certain scoring system and you have to follow those scoring system. Only if the patient necessitated surgery, you can take. And more importantly, the patient, the child, almost 16 or 14 years, I think, that boy, he had some other comorbidity also. So the anesthetist also didn't give good opinion for taking surgery. But then they forced the surgeon maybe in the other hospital also. And that's the reason why they took surgery. And he had a he had a cardiac arrest on the table and he succumbed to death. Okay, so why I am telling this is always follow the scoring system properly. That is why they have kept a scoring system. So for this patient, if you're going to see migration of pain, if it is there, that is going to give you score 1. Anorexia, it is going to give 1 more score. And nausea, mantral, and the name mantral, migration of pain to the right lower quadrant, that is 1. Anorexia, nausea, vomiting, N. Then T for tenderness in the right lower quadrant, that is going to give you 2. Tenderness in the right lower quadrant is going to give you 2 points. Rebound pain is going to give 1. Elevated temperature 1. Leukocytosis is going to again give 2. Left shift of WBC is going to give 1. Totally possible 10. If at all you don't remember this also, there is no problem, but this you need to remember. This is very, very important. M stands for migration of pain. A stands for anorexia. N stands for nausea and vomiting. T stands for tenderness in the right lower quadrant. R stands for rebound pain, and E stands for elevated temperature. L stands for leukocytosis, and left shift of WBC, that is going to be in total, it is going to give rise to 10 points. So total வந்து பாத்தீங்கன்னா எவ்வளவு points அப்படின்னா 10 points அதுக்கு வரும். So in the 10 pointsல actually if the patient is having less than 5, then there is very least chance. There is a very least chance for the patient to have appendicitis. So do not take for OT. If they are going to have 5 to 6, then also appendicitis is possible. Wait and absorb. 7 to 8 and the appendicitis is likely. So you can take the anesthesia fitness and you can take them for surgery. If it is going to be 9 and 10, 9 or 10, then it is an immediate appendicitis very likely. Immediately you can take for surgery. At the night day you can take for surgery. This is what is going to be your Avogadro scoring system. Okay, so appendicitis it's indicative for the acute appendicitis. Right lower abdominal pain, rebound tenderness, presence of pain when the pressure is removed from your abdomen. Possible mechanism is going to be pressure from manual, rightward movement of the small intestine, and pressure on the peritoneum. This is going to be your, what is this? McBurney point. This is going to give you the McBurney's point. Okay, remember. And then I'm going to tell you certain signs here, guys. I want you all to note it down. So there are certain signs that you need to understand. There are certain signs that you need to understand. You need to write it down in your exam also. The patient, the examiner will be expecting you. Okay, so there are some signs based on the location. Signs based on location. Just write it down. Number 1, retrocecal appendix. If it is going to be a retrocecal appendix, what you will have? Okay, if it is a retrocecal appendix, you're going to have psoas sign positive. Psoas sign positive. And patient keeps right leg in flexion. So patient is going to keep right leg in flexion. Patient keeps right leg in flexion. We already saw those signs, right? That same thing. And if it is going to be having a pelvic appendicitis, we know what is pelvic appendicitis, 5 o'clock position. Pelvic appendicitis. If it is a pelvic appendicitis, okay, so it is going to irritate the bladder and increased frequency. Okay, this is going to irritate the bladder. There is going to be increased frequency of urination, increased frequency of urination. Then it is going to irritate your rectum. Therefore, there is going to be an increased frequency of diarrhea, that we call it as pelvic diarrhea. Pelvic diarrhea. Okay, this is very important. And next one is going to be your pain. Okay, there is going to be pain. Okay, that is going to be a pain. Okay, wow, so that you need to understand. And next, finally, the third one, if it is going to be a post-ileal appendicitis. Post-ileal appendicitis. Okay, so what is going to be there? Hardly no signs will be present. So there is going to be no signs, and slight pain will be there. Slight pain will be there on deep pressure. Slight pain will be there at deep pressure. Okay, this is very important point. Now moving on towards the investigation of choice. So what is going to be your investigation of choice? Okay, listen carefully. Investigation of choice is going to be a CECT. CECT is the investigation of child. Okay, if it is going to be children. If it is children, you go for ultrasound examination. So ultrasound, ultrasound, you're going to see 3 things. Number 1, long tubular blind ending structure. Long tubular blind ending structure. Blind ending structure. Ending structure. That is the first one. Second thing is going to be your probe tenderness. Probe tenderness. Tenderness. Okay. Number 3 is going to be your periappendicular fluid. Okay, so these 3 are going to be important points for diagnosis in the children. Okay, what happens in your finding in your USG? I'll show you those finding in detail. So can you see here? So this is a finding. Okay, can you see here? 1 minute. I think this color will be going good. Okay, can you see here? So you're going to have a this is also very perfect. Okay, so very perfect. So what happens is there is going to be a blind denting tubular structure. There will be probe tenderness. Basically, you will have a probe tenderness. Appendiculolith can be present, and periappendicular fluid collections you can also visualize that. Okay, so what is going to be a management in these patients? I'll show you one more one. So this is a normal appendix. Can you see here? This is a normal appendix. In appendicitis, what happens? There is going to be a dilated appendix, diameter which is going to be more than 6 millimeter, and wall thickness more than 3 millimeter. So usually diameter must be less than 6 millimeter. Okay, well, so this is going to be your CT scan. So in CT scan, you can see very clearly, right? Can you see? So there is a dilation and fluid. This periappendicular inflammation. This is appendiculolith. Can you see here? There is going to be a stone formation. That is going to be a appendiculolith. Okay, this is going to be a appendiculolith. Okay, can you see here? This is going to be a appendiculolith. Okay, now this is going to be finally we are going to move towards. Finally, we are going to move towards what? We are going to move towards the treatment plan. So how we are going to manage the patient? Okay, write down. Just put the heading as management. So just put the heading as management. So what is your management? So first start with the NPO. First start with the NPO for the patient. Okay, NPO la vechidunga. Adukaprom give IV fluids. IV fluids. Number 3, IV antibiotics. IV antibiotics. Idella common one. Okay, antibiotic. Then you are going to give painkiller for the patient. Painkiller for the patient. Then for the purpose of appendicectomy, okay, you're going to go either lap appendicectomy or you can go for open appendicectomy. So appendicectomy currently it is done laparoscopically only. So appendicectomy da nama panna porom. So this can be performed either open or you can go for lap, but basically nowadays most commonly lap is only preferred. If base is inflamed, should not crush, bury with the bursting suture. So if it is going to be a base, so nama enna panna porom, base paaka porom. Okay, rumba important on a point. So very important. If you are going to go for the surgery, I'll base pakro. Base vandu pathanga, if it is going to be inflamed, don't crush it. Okay, do not crush it. Okay, you are going to bury it with purse string suture. Okay, purse string suture. I think I told you what is purse string suture at the beginning. So you can do this in the 2 things. I told you already in the beginning of the session, and while I am discussing general surgery, I told you that the purse string suture you are going to use in 2 important. Cervical encerclage use pannuvom, and acute appendicitis use pandrom. Rendu edathula da the purse string sutures we will be using. And if it is going to be gangrenous, if the base is going to be gangrenous, what you will do? You have to perform right hemicolectomy. Okay, you're going to perform. What are you going to perform? Right hemicolectomy. Right hemicolectomy. Colectomy. This is very important point again. Okay, if appendix is not inflamed, so base pakrenga, not inflamed. Okay, if it is not inflamed, what you're going to do is search at least for 2 feet of ileum. Okay, what you're going to do? You're going to search for 2 feet. You're going to search 2 feet. I told you, right? 2 formula. So 2 formulas. 2 rule of 2. We saw in Merkel's diverticulum. So C for Merkel's diverticulum, because Merkel's diverticulum is one of the most differential diagnosis should be made for your acute appendicitis. C for Merkel's diverticulum. Merkel's diverticulum. Okay, this is important. Okay, so what is going to be the traditional incision? So now you have to talk about what are the incision going to be. First, whatever we are going to do, we are going to perform a incision. Okay, so what incision is going to be given for the patient? So incision on the traditional incision is going to be your McBurney's incision. Okay, now what is, we have different types of incision basically. That is why this question is asked. Since you have many types of incisions, now the question can be coming like what type of incision you're going to put in this patient. Now I'll draw a simple, I'm just drawing abdomen. See here, this is going to be your okay, this is going to be a pelvic region. So this is going to be your umbilicus. So you have different type of incision. If you are going to put incision, okay, so you're going to have different types of incision, which is now I'm going to describe. Okay, number 1, this is going to be a McBurney's point. Okay, this is going to be a McBurney's point. When you're going to put an incision like this, this is called as your Lance incision. This is called as your Lance incision. They can label this question, this image can be given, and they can ask you in your exam, competitive exams, what is this incision called as? This is your Lance exam, Lance incision. And second thing, you can have incision something like this. Can have incision something like this. What is this incision called as? This is called as gridiron incision. This is called as gridiron incision. This is called as gridiron incision. Very important. Okay. So gridiron incision. This is a muscle split. So you have different mechanism. Gridiron incision is basically muscle splitting. Muscle splitting. And what is this Lance incision? Lance incision, basically it is going to be skin crease incision. Skin crease incision. Okay, then you are going to have another type of incision which is going to be given at the center like this. Okay, the incision is going to be given at the center. Can you see like this? You are going to have an incision. What is this incision called as? This incision is called as lower midline abdominal incision. Abdominal incision. Lower midline abdominal incision. Where do you do this more? Lower midline abdominal incision. So you give this for the perforated appendix. So CT paakrenga perforation irundaduna, you go for lower midline abdominal incision, perforated appendix. Okay, perforated appendix, and which is going to be a Rutherford-Morrison incision. What is Rutherford-Morrison incision? I'll give you. Okay, so this is going to be a Rutherford-Morrison incision. So this is going to be a Rutherford-Morrison incision. Rutherford-Morrison incision. Okay, so this is again muscle cutting. Okay, this is again going to be a muscle cutting. So what you're going to do basically, first you're going to put an incision, guys. Once you put an incision, so what are the structures these are going to pass through? First, it is going to pass your skin, then your superficial layer, then you're going to have your superficial fascia, then you're going to have your external oblique aponeurosis, then you're going to have muscles, you're going to split the muscle, then you're going to have your peritoneum, So if you're going to put a then if you're going to put a laparoscopic appendicectomy, so laparoscopy பண்ணும்போது you have to identify 3 ports. Okay, we will be giving 3 ports. Again, I'm going to draw something like this. Okay, so this is going to be a chest. Okay, this is going to be your chest wall. Okay, so this is going to be your navel. So what happens is you are going to put 3 important appendicectomy port. Okay, port engalam poduvenga. Idu or question actually once they asked this as one of the question. So you're going to put a port. Okay, what is going to be the how you are going to put a port? Remember, you are going to put an incision. Okay, if you're going to put an incision here, you're going to have 3 important ports you're going to put. What are 3 important ports? One is going to be here. This is going to be 12 millimeter port. And one you're going to put here, this is going to be 5 millimeter port. And here you're going to have one more that is going to be also 5 millimeter port. So these are the 3 ports which will be used in the laparoscopic appendicectomy. These are 3 important ports used in the laparoscopic appendicectomy. Ports used in lap appendicectomy. Okay, very important. And what are going to be the complications? Before moving to the complication, I'll tell you. First, you're going to open your peritoneum. After opening, you're going to identify the appendix. How do you identify the appendix? This I told you at the beginning of the discussion. How do you identify appendix? Okay, we are going to identify appendix by base. Okay, base is going to be present at junction of 3 tinea coli, that is going to be your appendix. Okay, that's once you are identified appendix, you are going to see normal appendix or inflamed appendix. Normal appendix na Merkel's diverticulum therno, inflamed appendix na appendicectomy. If the base is inflamed, what I told you, if the base is inflamed, do not crush it, bury it with purse string suture. If you are going to have gangrenous, then you are going to right hemicolectomy. So clear, guys? There is any doubt? Is there any doubt? No, right? Now you're going to talk about the management. So this till now what we were discussing is your management. You're going to put a McBurney's incision, Lance incision, or lower midline incision. So what is going to be your McBurney's incision? So McBurney's incision, now you have 2 type of incision: gridiron incision, Rutherford-Morris incision. Gridiron incision is going to be muscle splitting. Again, Rutherford-Morris is also going to be muscle splitting. Then you have Lance incision. You're going to have Lance incision, skin crease, or bikini incision. So this is going to be cosmetically, it is going to be better. And what is going to be lower midline incision? This is going to be a lower midline incision you do in the perforated appendix. You go for this in the perforated appendix. Now coming towards the complication, now you know the treatment. Now I'm going to move towards the complication. Remember, the most common complication, as I already told you, it is going to be wound infection. It is going to be wound infection. Wound infection is the most common complication, followed by hemorrhage. So the hemorrhage, and then you are going to have your injury to the iliohypogastric nerve. So there's an injury to iliohypogastric nerve, hypogastric nerve. Okay, this leads to increased risk of hernia. This leads to increased risk of hernia. This is going to lead to increased risk of hernia. And you're going to have number 4, portal pyemia, and you're going to have stump appendicitis. Okay, then what you have? Stump appendicitis. And number 6 you're going to have is your adhesive intestinal obstruction. Adhesive intestinal obstruction. This is going to be the most common long-term complication. This is going to be the most common long-term complication. This you need to understand. Okay, this you are going to understand. Clear, right? Yes. Keep along with me, guys. The first one is going to be wound infection. Number 2, hemorrhage. Number 3, injury to the iliohypogastric nerve. It is going to cause increased risk of hernia. And you're going to have a portal pyemia, stump appendicitis, and adhesive intestinal colitis. Most common long-term complication is going to be adhesive intestinal complication, adhesive intestinal obstruction. Next, you're going to have is your appendicular lump. What is appendicular lump? Basically, I'll tell you what is appendicular lump. So, appendicular lump abdina romba simple. Okay, so what you're going to do for a appendicular lump? Appendicular lump. What is going to be your management? So that is what we are going to discuss. So management we are going to discuss. I'll tell you easily how to remember. So you are going to perform a Sharon regimen. This was the first thing I mentioned when I'm going to discuss the index. So now index potamode, I told you this Sharon regimen is a very, very important. It is a conservative management. It is a conservative management which is expected by everyone. Okay, every examiner you will be expected to answer. So what is this? You have two important components. One is going to be monitoring component and other is going to be management component. Monitoring na enna pandreenga? Number 1, size of lump. You're going to monitor the size of lump. Number 2, tenderness. Okay, first one, size of lump. Number 2, tenderness. And number 3, you're going to look for temperature. And number 4, you're going to see pulse rate. Okay, I'll repeat once again. Number 1, size of the lump you're going to see. Number 2, tenderness. Number 3, temperature. And number 4, pulse rate. Okay, so these are the 4 things which you're going to monitor. And what are the 4 things which you are going to perform? Number 1, you're going to keep in NPO. Number 2, IV fluids has to be started. And number 3, IV antibiotics has to be given. IV antibiotics. And number 4, you're going to start with analgesics. So, 4 விஷயம் பண்றீங்க. Number 1, monitoring. Number 2, treatment. Monitorல 4 விஷயம். Size of the lump, tenderness, temperature, pulse rate. Size of the lump, tenderness, temperature, pulse rate. Again, I repeat, size of the lump, temperature, tenderness, pulse rate. Management, what you're going to do, you're going to keep the patient at MPO, you're going to give IV fluids, IV antibiotics, and analgesics. This is the management part. Okay, this ரெண்டும் சேர்த்ததுக்கு அப்புறம் நீங்க என்ன பண்றீங்கன்னா you're going to see, okay, whether the pain is decreased, whether the size is decreased, whether fever is reduced. Okay, what you're going to see, you're going to see whether pain is decreased, whether the size is decreased, and whether the fever is decreased. If it is going to be decreased, what you're going to do? If it is going to be decreased, you're going to discharge the patient. You're going to discharge the patient and you're going to call for follow-up after 6 weeks. Okay, after 6 weeks, what you're going to do? You're going to perform interval appendicectomy. Okay, wow. This is going to be interval appendicectomy. Okay, so if the pain is going to be more, if the size is more, if the fever is increased, then this is going to be a appendicular abscess. This is going to be appendicular abscess. And if it is going to be appendicular abscess, what you're going to do? You're going to abandon the conservative procedures. Okay, conservative procedure. Okay, you're going to abandon your conservative procedure and you're going to go for drainage of abscess. You're going to drain the abscess. You're going to drain the abscess. Very, very important. So after draining, how you're going to drain the abscess? I told you this also in the general surgery. You will be draining any abscess by using pigtail catheter. By using pigtail catheter. This is once again a very, very important concept. So you're going to use pigtail catheter. Next, we are going to discuss about the appendicular perforation. Appendicular perforation. What is this appendicular perforation, guys? Okay, appendicular perforation where the momentum doesn't work. So you will be performing, okay, so appendicular perforation, perforation the place where the momentum is not going to work. For example, in children, okay, in elderly patient, in immunocompromised, when the patient is going to be pregnant, or when there is going to be adhesions. In all these conditions, if you are going to see perforation, you go for what incision? Lower midline incision. Lower midline incision. Very, very important. And most common extrauterine abdominal emergency during pregnancy is going to be your appendicular perforation. So what is going to be your clinical features? Clinical features is going to be right iliac fossa pain, and sometimes there is your appendix is going to be pushed up. So appendix sometimes it is going to pushed up, and this is going to cause right lumbar pain. You're going to have a right lumbar pain. And what is going to be investigation of choice? Investigation of science, this is going to be most commonly occurring in the pregnant woman. Therefore, investigation of choice is going to be your USG. And what is going to be your treatment? Management is going to be lap appendicectomy. Can you tell me, can we do this lap appendicectomy in third trimester? Yes. In second trimester? Yes. In first trimester? Yes. So what you are going to remember is all trimester you can perform. All trimester you can perform appendicitis. That is what you want to remember. So appendicitis is one thing which you can perform preterm. Okay, before the term you can perform. After, okay, you can perform in the term. You can perform it in the first trimester, second trimester, anywhere. So that is one exclusive thing that is going to be present with your appendicitis in pregnancy. And finally, we are going to move towards the neuroendocrine tumors. Neuroendocrine tumors. So neuroendocrine tumors of appendix we are going to talk about. So 70% it is going to be at the tip. 70% it is going to be at the tip, remember. And most common it is going to be occurring in the age group of 50 to 60 years. And your diagnosis is going to be based on chromogranin and chromogranin and synaptophysin. Okay, chromogranin and synaptophysin. Chromogranin A to be specific. Okay, what is going to be a management in all these things? So management is going to be, if it is going to be more than 2 centimeter and close to the base. If it is going to be more than 2 centimeter and it is going to be close to the base. Okay, you are going to perform, okay, right hemicolectomy, right hemicolectomy. And if it is going to be less than 2 centimeter and if it is going to be away from the base, if it is going to be away from the base, what you are going to do? You are going to do a simple appendicectomy. Okay, you're going to perform simple appendicectomy. Very important. If it is going to be more than 2 centimeter and it's going to be close to the base, you go for right hemicolectomy. When it is going to be less than 2 centimeter and away from the base, you're going to have a simple appendicectomy. This is very important. Next, we are going to have certain epithelial tumors, which we are going to discuss. After this epithelial tumor, we will be approximately almost completing your appendix and we will be moving towards the small and large bowel. Are you all ready? Can we start? Yes. Okay. Yes. Are you all ready? Can we start? Yes. So we are going to move towards a very important topic that is going to be your epithelial tumors. Okay. So what is this epithelial tumor? So you are going to have two types of epithelial tumors divided. One is going to be your mucinous and other is going to be your non-mucinous. Non-mucinous அப்படின்னு பார்த்தீங்கன்னா it is going to have adenocarcinoma. So that is going to be consisting of adenocarcinoma. Adenocarcinoma, what is going to be a management? It is going to be right hemicolectomy. Right hemicolectomy. Okay, so what you are going to perform? You are going to perform chemo. Chemo is going to be FAFOX. Okay, you are going to perform FAFOX or Folfir. Okay, you're going to perform FAFOX or Folfir. Okay, this is going to be the regimen, FAFOX or Folfir. Okay, if it is going to be mucinous, it can present as A, mucocele. Mucocele, it is going to present as mucocele. Second is going to be your pseudomyxoma peritoni. Pseudomyxoma peritoni. What is the pseudomyxoma peritoni? It's a local invasive jelly-like material. Okay, right along with me, it is a local invasive jelly-like material. Jelly-like material in peritoneum. Okay, which does not metastasis. Doesn't metastasis. It is not going to metastasis. So see, it is going to be seen in. So this is going to be seen in appendicular tumors. Appendicular tumors. It is going to be seen in the appendicular tumors and ovarian tumors. Ovarian tumors. It is seen in the appendicular tumors. It is going to be seen in the ovarian tumors. This is going to be again seen in the peritoneal tumors. Any peritoneal tumor. Peritoneal tumors. And what is going to be your management? Management is going to be by, so what is going to be a management? You're going to do it by cytoreductive surgery. Cytoreductive surgeries. Okay, you're going to perform cytoreductive surgery, and this is going to be followed by IPEC. What is IPEC, guys? Hyperthermic intraperitoneal chemotherapy. Hyperthermic intraperitoneal chemotherapy. You're going to perform hyperthermic intraperitoneal chemotherapy. So what is going to be the temperature at which hyperthermic intraperitoneal chemotherapy is performed? It is performed at 41 degrees to 44 degrees Celsius. You're going to eat. Okay, eating it, what it happens? It increases the efficacy. It increases the efficacy. And then finally, you're going to give the drugs like paclitaxel, and you're going to give mitomycin, paclitaxel and mitomycin. Okay, with this we are actually completing the very important topic that is going to be your appendix. Okay, next you are going to have a small bowel and large bowel. I think today it will be very tired, so we will be next day, tomorrow we will see the small bowel and large bowel. So நாளைக்கு நம்ம small bowel large bowel முடிச்சிடலாம். So next session we will start with liver, then we will complete the liver and gallbladder at one stretch, and then we will go for pancreas. After completing the pancreas, it is going to be over your entire GIT. So I see here, every day you're going to progress little by little. Okay, so every day we are progressing little by little. After completing the topic, kindly take your SRB manual or whatever book you are going to referring. Try to match the topics. So these are the important points. There is to underline these important topics. So everything I took is from your Bailey and Love. So standard textbook I have taken the notes. So it won't be any problem, any issue for you. Okay, before concluding, let's see certain images, whatever we discussed today. So that will be helping you for actually preparing your exam. Okay, so I'll just show you the images that will be helpful. So what is this incision? This is going to be a gridiron incision, Lance incision, Rutherford Morrison incision. And this is going to show you appendix. I think all these things we have already seen. See here, this is the appendicectomy. The mesoappendix, what we are going to do, we are going to divide between the artery forceps and we are going to ligate it. Then after ligating, what we are going to do, then the ligating at the base of the apex, then Z suture is done to prior to the inversion of appendiceal stump. Then appendiceal stump is going to be inverted and you're going to keep it inside. Okay, this is another image of how we are going to do a stump the appendix. And this is a laparoscopic appendicectomy. Can you see a trocar? So you're going to have a trocar, you're going to have a laparoscope. Okay, this is going to be a trocar, this is going to be a laparoscope. This is how we perform the laparoscopic appendicectomy. Okay, so this is going to be a suprapubic line. So underwear line, this is going to be 3 millimeter, this is going to be 10 millimeter. Can you see here? And you have to remember what this is going to be the inferior epigastric vessels. How do you perform mesoappendix? How do you perform appendicectomy? Tomorrow we are going to start with the next important topic, that is going to be small bowel, large bowel. So let's hope the discussion goes well. If you have any doubt, you can just put it in the chat box, comment box, or in my own WhatsApp number, which is I think most probably you all will have, or in the group you can put, so that it will be helpful for you. And I will give you all the suggestions and help whatever you need. Okay, thank you so much. Have a good day.